All right, hey guys. I decided to record this last part of Chapter 29 lecture. I'm not going to be able to do the live Blackboard Collaborate Thursday, so this will be the recorded lecture for you. So this is our last class, our last lecture. So I just wanted to, really express how impressed I've been with everybody's ability to kind of keep up with things during this online transition, and I hope that I was able to keep things, with as much continuity as I could for you, and you still were able to kind of get a lot out of the class through the online labs and lectures and things like that. So again, thank you for your cooperation with this. I wish you guys all the best going forward. If you need, have questions about things in the future, you can always reach out to me. It looks like for those of you that need Anatomy 1, I may or may not have an Anatomy 1 class coming up this summer. It's either going to be that or the Anatomy 2 class I'm going to have in the summer. It just depends on the numbers, which one I'm going to have. And it'll be an online section. Obviously, all the classes are online in the fall. And then I will have an online section of Anatomy 1, or I'm sorry, they're all going to be online in the summer. I will have most likely an online section again in the fall. All right, so I won't be teaching in person in the fall. I'll be teaching just online. So if you haven't had Anatomy 1 yet, maybe I'll see you at some point, or I'll see you in other courses here at Rowan too if I, decide to teach in other classes. But like I said, it's been really a pleasure to teach some of you guys for the 2 semesters or even the 1 semester, even though this has been kind of crazy. I really do feel like a lot of you have been a really it's been a great experience for me to teach a lot of you. So thank you for that. All right, so let's then dive into this last part of chapter 29 and wrap up the lecture and wrap up the course. So if you haven't done so already, I strongly suggest you take a look at this animation on fertilization and development. All right, so let's pick up talking about teratogens. So thinking about that embryonic period and how quickly things are, rapidly changing, it makes sense that any sort of agent is going to possibly cause problems in the embryo, right? So chemicals, drugs, anything that's going to cause, a developmental change in the embryo is a teratogen. So most commonly, it's going to be alcohol we're going to see, and that could lead to fetal alcohol syndrome, which is going to affect the development to varying degrees of the baby. But other drugs can also cause this. There's viruses that can be teratogens, like the Zika virus, industrial chemicals, hormones as well, and antibiotics. So we see antibiotics and hormones in meats causing possible, embryonic harm, reproductive harm. Drugs such as cocaine can affect it as well. So all of these things are teratogenic, meaning that they're going to cause developmental defects on embryo. So, you may see things like this and may say, pregnant women should not handle this drug or something like that, because it can cause developmental problems. Another major problem can be due to cigarette smoking. So during pregnancy, cigarette smoking coupled with alcohol is really a bad situation, but cigarette smoking has been implicated as a cause of low birth weight, cardiac abnormalities, anencephaly, which is when the baby is born with no brain, higher infant and fetal mortality rates, meaning a higher death rate. Radiation is also teratogenic, so exposure to X-rays, radioactive isotopes can cause microcephaly, which is same thing as the Zika virus, which is a very small, underdeveloped brain. And mental retardation and skeletal deformities can also be the result of radiation. Okay, so not good. And there's been other teratogens that have come out in the past. There was the thalidomide drug that was taken, I think, in the 40s, 40s or 50s. It was to treat morning sickness, I believe, in pregnant mothers, and it caused deformities and lack of limbs in babies when their mothers took that drug, uh, which is not safe for pregnant women. So things that can be safe for other people may not be safe for women who are pregnant. Okay, so there's various tests that are done that can look at and determine, if there's any abnormalities or genetic disorders, and even just test to see, okay, are you pregnant, right? And these prenatal diagnostics tests will do that. So the most common one that's done is an ultrasound, so fetal ultrasonography, used to determine accurate fetal age when the date of conception is a little bit, I'm not sure when we got pregnant. You can also take a look and see, are you pregnant? Where is the baby's position? Is the head facing down, preparing for labor? Identifying multiple pregnancies, are there twins, triplets, or even more so? Other uses, you can determine, the sex of the child as well using a ultrasound. All right, so this is commonly done. It's just uses light weights, minimally non-invasive at all, and is used to determine pregnancy. Amniocentesis is a much more invasive test that's done earlier than, in some cases, the ultrasound. And what the amniocentesis can tell you is if there's a genetic abnormality. You can't get that from an ultrasound. An ultrasound just shows you an image of the baby. But amniocentesis will show you the actual chromosomes. You're looking at cells here. And these cells from the amniocentesis can tell you, okay, are there genetic defects? Okay, so this is usually performed between 14 and 18 weeks. And like I said, this is an invasive procedure where a needle is used, guided by an ultrasound, to collect the amniotic fluid. And the cells in the amniotic fluid that are sloughed off of the uterus contain fetal DNA. Okay, so these cells will allow for testing to see, okay, are there genetic abnormalities? So here's what this looks like, right? So you can see this can be a potentially dangerous procedure because you're sticking a needle into the uterus, and anytime you're kind of puncturing the womb like this, it could potentially lead to triggering a premature labor, which you don't want to have happen, obviously, at this early stage. Also, you don't want this needle to touch the fetus, right? That's why they use the ultrasound to guide it in, all right? But then we take some of that amniotic fluid with the fetal cells in it, and we can look at the DNA and determine, okay, are the chromosomes correct in there? Is there a problem that we can look at and potentially, if there's anything we can do about it? Another test that's done, prenatal test, is looking at the chorionic villi. So here we're looking at the cells of the chorionic villi, and this can be done earlier. And generally, this test is just done to see the same thing, genetic defects, and the only difference is that it's done a little bit earlier. Under ultrasound guidance, again, insert a catheter through the vagina and cervix to collect a tissue sample from the chorionic villi. All right. The goal is to identify, again, genetic defects, same as amniocentesis, and it can be done through the abdominal walls as with amniocentesis. Okay. So there's two ways, like I said, it can be done. It can be done with a catheter here, which the catheter goes in and samples the cells, or it can be done with a needle, where the needles take the cells out. And again, you look at them, you look for abnormalities. So these tests, CVS, chorionic villi sampling, which is abbreviated CVS, and amniocentesis are only done when there's a likelihood that there's some kind of problem that needs to be looked at. So an older mother, or if there's a history of some kind of genetic defect, these tests will be done. Generally, people don't get these done because they are a little bit dangerous. There's a risk to the mother and a risk to the fetus to get these tests done. Okay, so we don't see these happening unless, a normal, healthy kind of pregnancy that's not high risk, you wouldn't get these done. There's also non-invasive prenatal tests that can be done. They're not as informative as amniocentesis and chorionic villi sampling, but they don't have as much risk. Okay, so this AFP test, maternal alpha fetoprotein test, requires a blood sample from the mother, and what it does is it detects this protein AFP produced by the fetus at its highest levels between weeks 12 and 15, and then after the 16th week of pregnancy, normally the levels of AFP should go down to 0. So if we test the blood and we see that there is a high level of AFT after week 15, then we can assume that there is some sort of problem. Okay, and that could indicate a neural tube defect or deformity. All right, so those are all the diagnostic tests that are done. Let's talk about some of the changes that happen to the mother during pregnancy. During the first 3 to 4 months of the pregnancy, the corpus luteum, so remember the corpus luteum, the egg is released, and what's left is the corpus luteum after ovulation, and the corpus luteum releases progesterones and estrogens until menstruation. Now here we're not having menstruation take place, so the corpus luteum continues to secrete progesterone and estrogens in low levels in the early 3 to 4 months of the pregnancy. From the third month to the end of the pregnancy, the placenta produces high levels of these hormones. So after the third month, the placenta takes over as the real source of these hormones. The chorion secretes HCG, which we talked about earlier in this chapter, and HCG is only produced during pregnancy. So this hormone stimulates the corpus luteum to produce estrogens and progesterones to inhibit menstruation until the placenta takes over, right? So the purpose of this hormone is to stimulate the corpus luteum to continue to produce progesterone and estrogens, whereas it wouldn't if there wasn't a pregnancy. And this hormone here, this HCG we talked about, is the principal hormone that is tested for in a pregnancy test because your female is making a lot of it when she's pregnant, and some of it ends up in the urine. You can test for it with a urine test. All right, so here's the hormones that are released during pregnancy. So pretty cool. So here's HCG, like I said, that human chorionic gonadotrophin hormone, which is a releasing hormone, and it's going to rescue the corpus luteum from degeneration. So normally, if there's not a pregnancy taking place, corpus luteum will release its progesterone, estrogens, and then it'll go on and it'll turn into that little scar, right, the corpus albicans. Here, that's not happening, right? HCG is going to basically tell the corpus luteum to continue producing those hormones, progesterone, estrogen, and what that does is it maintains the uterus lining, prepares the mammary glands for lactation, producing milk, which we'll talk about in a bit, prepares the mother's body for birth. Okay. So the corpus luteum is going to stimulate the release. So all these things are coming from the placenta. Stimulate the release of relaxin from the placenta. So what's relaxin do? It increases flexibility of the pubic symphysis, helps dilate the uterine cervix during labor. So that's going to come back to this too. Human chorionic somatomammotropin. Okay, so lots of prefixes in there to look at. There's the mammary glands for lactation, enhances growth by increasing protein synthesis, so the growth of the mother's body, and also decreases glucose use and increases fatty acid use for ATP. Now, fatty acid is much more energy dense than glucose, and the mother is going to need that energy to not only, provide for herself, but also now for the baby, and for the needs of labor, which we're going to see is very difficult. Corticotropin releasing hormone establishes the timing of birth and increases the secretion of cortisol, which we'll talk about. Cortisol, which is the stress hormones, and cortisol is going to also play a role in producing surfactant in the fetal lungs. Okay, so the baby can breathe when it comes out into the air. These are the hormonal changes that occur during pregnancy to the woman. So here's a look kind of at what's happening in a graph. All right, so here's the age of the embryo from fertilization all the way to 40 weeks. So we can see early on we have this huge spike in HCG, right? And then that will continuously decrease because that is stimulating the release of more progesterones and more estrogens, right? So this change where we start to see progesterone decreasing and estrogens increasing is what is going to stimulate the beginnings of delivery. Okay. So, like I said, HCG will peak about the 9th week of pregnancy. The chorion secretes estrogens after the 3rd or 4th week of pregnancy and progesterone by the 6th week. And you can start to see that those changes here will continuously increase once we get to the chorion and the placenta producing those in response to the spike in HCG. Relaxin is secreted by the corpus luteum, later by the placenta, and it increases the flexibility of the pubic symphysis and the ligaments of the sacroiliac and sacrococcygeal joints, which are going to help to dilate and open up the cervix during labor. So the cervix is going to dilate in centimeters, okay, ultimately accommodating the baby's birth. HCS, human chorionic somatomammotropin, also known as human placental lactogen, okay, is a hormone that's thought to prepare the mammary glands for lactation, help maternal growth, regulate metabolism in the mother and fetus. All of these things are ultimately leading to birth and even beyond birth with the production of milk through lactation. The hormone recently discovered to be secreted by the placenta is this corticotropin releasing hormone, or CRH. Okay? In non-pregnant people, it is secreted by the hypothalamus, and then in pregnant women, it's secreted by the placenta. Okay, so what is this CRH doing? It increases the secretion of cortisol, which again is that anti-stress hormone, and certainly maternal changes are going to require anti-stress. But specifically here, we're talking about the maturation of fetal lungs and the production of surfactant, because we're going from the fetus, which is not going to be using its lungs to breathe. The oxygenated blood is coming directly from the mother through the placenta to the umbilical cord to the baby's fetal circulation, right? It's not breathing, it doesn't need to. Once it gets out of the mother, it needs to immediately be able to breathe, right? And when it breathes for the first time, it's going to cry. And that's why it's such a great moment when a baby cries, because it means those lungs are taking in the air. Okay. Throughout pregnancy, the uterus continues to expand, moving upward into the abdominal cavity, pushing everything out of the way. Pressure on the stomach can cause food to shift around, going back up into the esophagus, causing heartburn, right? It's also pushing on the bladder the whole time, right? And wait till you see this next figure, pretty insane. Okay, so remember how small the uterus was when we looked at the reproductive system. Right now, the uterus is literally taking up, at a full-term pregnancy, the entire abdominal cavity, right? So everything is pushed out of the way. Breathing is difficult, all right? Like I said, pushing on the bladder. Everything at the end of a pregnancy is very, very uncomfortable for the mother, okay? For those of you that have watched The Miracle, Life's Greatest Miracle, I hope you have maybe some new appreciation for what our moms have gone through. The end of that video is, it's pretty real, but pretty amazing what happens through this whole process from one cell to an entire person, billions of cells. So this is what's going on here, the abdominal cavity. So make sure you take a look at this animation of the hormonal regulation of pregnancy and childbirth. You get a better understanding of this. So it's important that pregnant women do exercise as well, but it's not going to be to the same degree as maybe that they exercise before pregnancy. So if someone's a runner, a pregnant woman can still continue to run while she's pregnant, but she may go slower or less timing, and then towards the end of her pregnancy may just move to walking or doing lighter things. right? Because a lot of energy is going towards the baby, so it's taking away from the ability to do other things. Okay? So early in the pregnancy, the mother tires easily, may suffer from morning sickness. We don't know what causes this morning sickness, and it can be different for different people, the degree of it. Usually early on, sickness, the pregnancy can trigger a little bit of sickness, but if it's very serious, it's important that the mother does go to the doctor, talk about that, because if she's throwing up, she's losing that food, which is fuel. So it's something that needs to be taken care of safely. Okay, during the pregnancy, weight will increase. Obviously, you've got this giant thing growing in you that you need to support. Posture is going to change because now we've got this added weight in the front of the body. All right. And increased relaxin levels cause change in gait and stance. All right. And that's going to affect, again, the overall posture and the ability for the pregnant mother to move around, all preparing ultimately for labor. All right. So labor, we're getting to the end here now. The process that expels the fetus from the uterus through the vagina. Parturition is another name for labor as well. Several hormones initiate labor. Okay, we'll talk about them in a second. Oxytocin being the major player here. And you want to recognize that this is one of the few systems in the body that are controlled via a positive feedback cycle, meaning that these contractions are going to continuously feed back and produce more oxytocin with each successive contraction, right? So just like any muscle contraction, the uterine wall contracts once, not as forcefully. After that contraction, it initiates the hormonal response to send a faster, harder contraction, and each one is harder and faster until the baby is born, when it starts to slowly go down. All right, so we'll look at that in a second. So once those uterine contractions, like I said, the feedback is very hard and very regular. It's true labor. Okay. So this is going to happen after there's some initial early contractions called false labor. So these are irregular and there's no show. So what that means is that once the baby is ready to be born, that mucus plug that we talked about in the cervix has to discharge. So once the mucus plug discharges, then some blood and mucus will leak out. And once that happens, the baby must be born within, a 24-hour time period. Okay. So that's when it becomes, very serious. You're very close. True labor is divided into 3 stages. Stage of dilation of the cervix, stage of expulsion, and then the birth of the placenta. Okay, so let's look at these 3 stages here. So we've got the stage of dilation first. And signaling the stage of dilation, the doctor will measure using their fingers the amount of centimeters by which the cervix has dilated, and that will indicate how close we are to the next stage. Right, so the baby can't be born unless the amniotic sac is ruptured. So remember, we got this amniotic sac all around the baby, right? Once we're getting close to birth, it's going to push through, it's going to break that, and that's when a woman's water breaks. It's really the rupturing of the amniotic sac. If it doesn't happen by the baby's head, the doctor will go in and kind of poke it with a little hook and do it himself or herself. That will initiate the first wave of contractions. And what'll happen is essentially oxytocin in this process. So the baby pushing down and the contraction of these muscles signals the release of oxytocin. And oxytocin is then going to bind to receptors in the uterus and cause it to contract harder. Okay. With each contraction, more of that oxytocin is released and a larger message is sent, and more oxytocin receptors are bound to in the uterus, and more forceful contractions occur. Okay, so what's happening here when that oxytocin binds is the woman is going to feel a very strong uncontrollably strong urge to push. Right? Uncontrollably strong urge to push, and what starts to happen is stage 2. That overpowering urge to push leads to the stage of expulsion, where the baby is released. And this here to here can take anywhere from 20 minutes to 20 hours or more. Just all depends on the person and the labor. Okay. So once the baby's born, that oxytocin doesn't shut off completely. It's still bound to those receptors, but it's going to start to kind of backpedal a little bit. As that oxytocin backpedals, we get the birth of the placenta. So there's still little pushes that are continuing, not as strong as this one, but strong enough to remove the placenta with the umbilical cord and all of that stuff out of the body. All right. This will continue to shrink the size of the uterus even after the umbilical cord and the placenta are birthed. All right. So, like I said, it's not just a light switch. Following delivery, it takes about 6 weeks for the maternal's reproductive organs, the size, the shape, the physiology to return to their pre-pregnancy state. Puerperium is this period, and it involves something called involution, the reduction in the size of the uterus. Like I said, is due to the decreasing amounts of oxytocin shrinking the inside of the uterus. Okay, so it some things will shrink back completely, but this 6 weeks is taxing on the mother. She's still gonna be tired. This is, look at what just happened, right? This is not an easy thing. So it takes 6 weeks to kind of return to normal from this trauma. And some things never go back. So the size of the hips and things like that will stay kind of larger post-labor. So those are the changes that kind of happen to the mother at birth and after birth. The infant still isn't done. So during development, right, inside the mom, the baby's totally dependent on the mother for survival, right? It cannot survive. It has the placenta, getting oxygen, everything. At birth, the fully developed newborn body begins to function now independently. So like I said, it needs to breathe. That's the key thing. So the lungs are able to exchange oxygen and carbon dioxide thanks to that surfactant, which we talked about, which began to develop by the end of the 6th month. All right. At birth, the respiratory rate is 45 breaths per minute, dropping to the normal 12 breaths per minute in 2 weeks. Right? It makes sense. It would be really fast. To begin with, this is the first breaths that baby is ever taking in its life. It's a brand new experience that it's going through. So it's going to be much more. It's crying, and it's very it's different. It's not an easy thing for the baby to do at first. So after the baby's first breath, all of a sudden the cardiovascular system now has its own oxygen supply. The fetal circulation, where blood was just mixed, is no longer going to work. It needs to have the separated 2 halves of the heart like we have. So the foramen ovale, which was that opening between the right and the left atrium in the fetal heart, is going to close off. And that becomes the fossa ovalis, which you might remember from the heart. The ductus arteriosus closes and becomes the ligamentum arteriosum. So between the aorta and the pulmonary artery, there was a little connection. All right, that's going to become tight with connective tissue and close off. Umbilical arteries fill with connective tissue as well. Okay, we don't need those anymore. Umbilical vein becomes the ligamentum teres of the liver, right? So all these things just sort of change to meet the needs of now the fully functional, independent human. So what happens if these things don't actually change? You get congenital heart defects. So here, the ductus arteriosus, which is supposed to fill up with connective tissue here, okay, is going to remain open. So here's the left side of the heart, remember, with your oxygenated blood, and then that oxygenated blood is supposed to go out to the rest of the body through the aorta, but here, some of that oxygenated blood is actually getting mixed in with this deoxygenated blood, right? We don't want that. We want all the oxygenated blood going to the body. So this can be easily corrected. Sometimes these will resolve themselves, but if this needs to be corrected by surgery, they can go in and they can tighten around this and close it off. Right. The more serious one, both of these are serious. You don't want to have heart surgery. your infant. But if the foramen ovale fails to close, a hole in the heart, sometimes this is caused. So remember, this is the opening between the right and left atrium. So here again, we've got the same thing. Blood comes in, and instead of going just down into the ventricle here, it is going into the right atrium. All right. So again, we want all that blood to be pushed out into the aorta. We don't want any of it going and going into this deoxygenated supply, because that means some of it's not going to the body. All right. So this can be fixed as well with surgery, or it can resolve itself on its own. All right. So this is just showing you side by side what fetal circulation looks like and what a baby at birth circulation or our circulation. So this should look very familiar. We talked about this in detail already when we did pulmonary and systemic circulation. Okay, but you can see the differences in fetal circulation because the lungs, you're not breathing through your lungs as a baby. Okay, so you're not getting oxygenated blood from the lungs. Instead, you're getting oxygenated blood from the placenta, right? And then that oxygenated blood from the placenta is going to go to, the tissues and things like that, and then ultimately mix with deoxygenated blood in the heart, okay, return back to the placenta as well. And when it returns back to the placenta, it'll mix with the mother, and it's a continued cycle of just blood going to the mother and being recycled through this placenta. But you get this mixing, and then here that is gone, and this shows you all of the changes that occur. Okay, so you don't have obviously the umbilical vein and the umbilical artery for that oxygenated, deoxygenated blood. Okay, so last couple of things here. The physiology of lactation. So lactation is milk production and ejection from the mammary glands, and we've talked about prolactin. Okay, so normally if you're not producing milk, a woman's not producing milk, there's a prolactin inhibiting hormone that's going to stop the production of this. But birth will trigger the production of prolactin secreted by the ant pit, and that is the main hormone stimulating milk production. Oxytocin, talked about already as being the major birth hormone, causes the release of milk into the mammary ducts via the milk ejection reflex. All right, so pretty cool here. So here's the controlled condition. So when the baby begins to suckle, okay, that touch sensation is received by receptors, sensory neurons in the nipple, which sends the message via nerve impulses to the hypothalamus and the posterior pituitary to release more oxytocin. More oxytocin means that the cells in the mammary glands are going to produce more milk. All right. When the baby stops suckling, then the process will kind of feedback will stop. If it continues to suckle, then it'll continue through positive feedback, producing more and more milk. Breastfeeding has its advantages. So the mother's milk is designed for one purpose, to help with the baby's developing brain. She confers immunity, right? So that passive acquired immunity we talked about, the immune system, is passed from mother to child through breast milk. So the antibodies that are in there and all those things are great for the baby. Breast milk is best for optimal infant growth, and it leads to, obviously, with all of these things, a reduction in the risk of several diseases. If someone can't breastfeed, then there's formulas and things like that that can replace breast milk and provide, all of these things just as well as breast milk if someone can't breastfeed. All right. Last bit here, the disorders of the reproductive systems and development, right? So we talked a little bit about infertility. For the males, it can be, low sperm count, low motility of sperm. For the females, there could be a whole slew of hormonal issues, polycystic ovary syndrome, that can cause problems with this uterine menstrual cycle, right? Sometimes the female environment can be inhospitable for the sperm, right? And that can be on both sides. But there's blockages, there's irritants, things like that can occur. There's lots of congenital developmental defects. Talked about the ones with the heart. Anything that can affect the development of the baby is a congenital defect. Down syndrome is the result of a genetic defect where there is an extra chromosome. And the extra chromosome, number 21, leads to the clinical features of Down syndrome. And Down syndrome happens more likely later in the mother's age when the eggs are not as well protected by the follicles and they degrade over time. We start to see mistakes happening in meiosis II at that point. All right, so that's it. That will wrap up anatomy and physiology 2. So at this point, you should take the quiz on chapter 29. It's 20 questions, multiple choice, and you have a half hour to do that. It should be open Thursday, which is today. If you're watching that today, Thursday, open about 4 o'clock. So make sure you go in and do that. And then your exam will be available next week, Wednesday and Thursday on Wiley Plus. All right, and the exam, like I said, will be 100 questions, multiple choice. So make sure you know kind of what you're doing and can find the answers to things if you need to fairly quickly, because that will be timed. And things that you do know, make sure that you're comfortable with them as well. All right. So if you have any questions, the review guide is available with the objectives. And best of luck to all of you, like I said, in any future courses that you take. And I hope to see you around campus. Have a great summer.